Hi, everyone. We'll get started very shortly. Hi, everyone. Welcome to today's webinar, Healing Through Pelvic Floor Physical Therapy. I'm Kitty Silverman, Share's Uterine Cancer Program Director. Before the presentation begins, I'd like to tell you a little bit about Share. We're a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancer and provides outreach to the general public about signs and symptoms. For more information about upcoming webinars, support groups, and our support lines, please visit our website at sharecancersupport.org. Now we have a few housekeeping reminders for you. All participants will be muted during the presentation. Once our speaker finishes presenting, we'll begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of your screen. Remember that the speaker cannot give specific individual advice, so please keep your questions general in nature. And thank you to everyone who pre-submitted questions during registration. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. Lastly, this webinar is being recorded. In a few weeks, we'll share the recording with all registrants and add it to our website. Now I'd like to hand it over to Dr. Lily Jilk to introduce herself. Take it away, Lily.
All right, hello. Let me just share my screen in a second. But yes, my name is Lily. I'm a physical therapist. I'm a pelvic floor specialist, treating in New York City at the time. I graduated from the University of Minnesota, and prior to that, I went to Macalester College in Minnesota as well, but I'm living and working in New York City now. I've been a pelvic floor physical therapist for a little bit over 6 years, working with many different types of patients, pregnancy, postpartum, a lot of male patients, lots of cancer patients as well. I'm very happy to be here today and to provide this information to you all. I'm biased, but I think it is obviously very, very important. So as Kitty mentioned, the topic today is healing through pelvic floor physical therapy. A little bit about me. This is what I just told all of you, but that is me smiling there. So what we're going to go over today, I'm going to introduce pelvic floor physical therapy, pelvic anatomy, and pelvic physiology. I'm going to briefly discuss cancer treatments and the possible impacts on the pelvic floor. It's just really good to have a baseline knowledge of what the pelvic floor is, what pelvic floor PT is, what the pelvic floor looks like, and how the different cancer treatments can impact that. I'm going to describe a pelvic floor physical therapy evaluation. So if anyone has not had pelvic floor PT before and is curious about what that may look like, just to really provide a good outline what to expect. And then importantly, I will also be talking about pelvic floor physical therapy treatment techniques and various different ways that you can promote healing and promote recovery. And then if we have time, I will also go over some case studies as a nice way to wrap everything up. And then there will be time for questions after. So you will learn what the pelvic floor is, how it relates to daily function, and what to expect as a patient in pelvic floor physical therapy. You will learn how cancer and cancer treatment can impact the pelvic floor and lead to pelvic floor impairments. And then you will also learn key treatment concepts to improve cancer-related pelvic floor impairments. So pelvic floor physical therapy, what is it? Well, let's start by talking about what is the pelvic floor. The pelvic floor is a group of muscles, ligaments, and connective tissues that span the bottom of the pelvis like a hammock or sling. These structures support the pelvic regions and can provide stability and continence. So I always tell my patients that, because a lot of times people come into the clinic for the first time and they have no idea what the pelvic floor is. They don't even know they have a pelvic floor. The pelvic floor, they're muscles just like muscles anywhere else in your body. They sit like a hammock. So if any of you are sitting right now watching this presentation, you are sitting on your pelvic floor muscles. I'm going to talk more about the anatomy later, but just a brief overview of the anatomy. There are 3 different layers within that hammock. Those muscles work in coordination with the diaphragm, the abdomen, and the back muscles. So again, it's called the pelvic floor. I like to imagine the pelvic floor is the floor, the diaphragm is the ceiling, the abdomen is one wall, and the back muscles are another wall. So we have muscles down there, and we need to be able to contract them. We need to be able to relax them, and we also need to be able to lengthen or bulge as though we're like bearing down. And within all of that, the pelvic floor muscles, again, they help to support our organs, our bladder, uterus, prostate for men, rectum. They help to maintain urinary and fecal continence, so prevent leakage of urine or poop. They play a vital role in sexual function, and then they also stabilize the pelvis and spine. They have connections directly into the spine, into our abdomen, so they help to stabilize us when we're doing everything throughout our life. And then also importantly, it helps to assist in circulation and lymph flow. So then what is pelvic floor physical therapy? It is physical therapy, just like physical therapy for any other part of the body. So if you've ever had physical therapy for your knee or for your back, it is the same thing. It's just applied to a different part of the body that's a little bit harder to access. But we're still talking about muscle strength, muscle coordination, muscle flexibility. We're still trying to reduce pain, improve function. But because of where it is in the body, it's helping to restore bladder, bowel, and sexual health rather than helping you walk up the stairs. And specifically with pelvic floor PT as well, oftentimes we're supporting recovery after surgery, after cancer treatment, again, postpartum, various different things. And again, just like physical therapy for the knee or the back or the neck, we're providing hands-on techniques called manual therapy. So a lot of times this is massage-like. We're providing biofeedback and coordination training to allow for improved connection with the muscles. We're teaching exercises, so that can be stretching exercises for the pelvic floor and for the pelvic muscles, strengthening exercises, both isolated at the pelvic muscles, but also zooming out a little bit into the abdomen, into the hips, sometimes even lower extremity strengthening. So leg strengthening is very important for the pelvic floor. And then lastly, education behavioral strategies. So again, it's like physical therapy for any other body part. It's just in the pelvis. I'm not going to read all of these, but these are just some of the many conditions that pelvic PT can treat. So leakage, whether that's caused by impact or whether it's caused by a trigger, going to the bathroom frequently. So normal urinary frequency going to the bathroom should be about every 3 to 4 hours. And a lot of people are shocked when they hear that because sometimes they'll be going every hour or every 2 hours. And likewise, also waking up at night to go to the bathroom frequently. Will help with painful bladder syndrome, low back pain, tailbone pain, pain with penetration, pain with sitting, constipation, and that's just some of the things that we can help with. So, pelvic floor anatomy. I want to go through this pretty quickly because I think it's important for patients to have a baseline knowledge of what the pelvic floor is, but we don't have to get too dug down into the details. But I think that when we're providing an intervention, especially because this can be a very sensitive area and a sensitive topic, we need patients to know why they're doing that. And you can really only know why you're doing something if you understand what's going on there. So, pelvic floor anatomy. Again, if we go back to that hammock idea of the pelvic floor muscles sitting like a hammock at the bottom of your pelvis, there are 3 different layers to that hammock. This picture is showing a bottom-up approach. So we have the pubic bone on top, we have the tailbone on the bottom, and then we have the 2 sit bones on either side here. And those are the bones that you're sitting on. Again, if you're sitting right now watching this and you move yourself side to side, those are the bones that you are kind of rubbing against there. So this layer is the closest to the chair. It is the most superficial, and it is very thin. You can see this is here going around the vagina. This is going around the rectum. And these muscles are mostly involved in sexual function, and they support sexual health. The second layer, if we go up just a little bit, so I know this diagram is a little bit unclear, but right here, this is the vaginal canal. We have the urethra right on top of that. This second layer, just a little bit more in, is the sphincter control. So these are the muscles that are really involved with keeping in urine and allowing urine to flow out. So we can see, this is important to note because we can see how if these muscles are tight and they're wrapping around the vaginal canal more tightly, that could cause pain with penetration. And then it can also cause pain with urine trying to flow out if that's really tight. It can also cause issues with allowing urine to flow at all. And then if these muscles are weak or damaged, then we could see how maybe urine would be flowing without as much control. And then the third layer is the pelvic diaphragm. So if you do a Kegel, if anyone knows what a Kegel is, I'll come back to that later. The muscles that you're really feeling when you do that are mostly this layer. So this layer is the layer that's providing support and stability to our pelvis. It's supporting all of those organs. It's like the thick, meaty, muscular layer. And here again, we have a bottom up approach. So this is the back side here. This is the tailbone. This is the pubic bone in front. And then we have all of the muscles here. So the pelvic wall is also part of this. So it's not the pelvic floor itself, but these two hip muscles over here insert into the pelvis. And I'm pointing that out because if there is a period of immobility due to cancer treatment, or if we find ourselves sitting more, that can cause hip tightness at times. And that hip tightness can contribute to pelvic floor dysfunction as well. These two hip muscles go into the pelvis, and that can impact things that people are feeling. I love these two pictures because they show how the urethra, the vagina, and the rectum literally go through the muscles, which again ties back to the treatment very importantly. So we have a female here on the left, and on the right we have the male. Yes, males have pelvic floors as well. And actually about like half of my patients are men. But I am focusing more on female anatomy today and female cancers, but it is important to note that men also have pelvic floors. So you can see here how, again, we have the pubic bone in the front, the tailbone in the back. These muscles travel from the front to back like a hammock. It's a little bit easier to see on the male, but moving from front to back like a hammock. And the urethra goes through those muscles. The vagina goes through those muscles. The rectum goes through those muscles. So again, if those muscles are tight for whatever reason, maybe there's issues with constipation because now there's a squeeze pressure around the rectum. If they are tight around the vaginal canal, again, pain with vaginal penetration. If they are too loose, we could have urine flowing out when we don't want it to. So I really like this because it shows how that relationship is between our organs and our pelvic floor. These are also really important to note because there's a lot of other things going on in that area. It's not just the muscles, it's not just the bones. On the left, these are just some of the nerves that travel through the area. So I just wanted to paint a picture of how, again, cancer treatment in the area, surgery in the area, just pelvic floor muscle dysfunction that's resting at that point no matter what. It can impact the nerves, it can impact sensation, pain pathways can be changed because there's a lot going on here. Similarly, on the right side, this is all the lymph and lymph flow in that area, the lymphatics. So again, we can understand how surgery to the area, a lymph node dissection, anything like that can implicate the pelvic floor because it's all sitting there together. Okay, which brings me to the next part, which is pelvic floor conditions and gynecological and breast cancer and how they can play in together. Why am I doing this talk, really? So here are some cancers that can impact the pelvic floor. So the female cancers, uterine, ovarian, cervical, kidney, urinary, colorectal, vaginal, vulvar, and breast. Again, any surgery, any localized treatment to the pelvic region that can impact the pelvic floor muscles and pelvic floor health. But also breast cancer, it's important to put on there because hormone therapy, especially anti-estrogen therapy, can have effects on the pelvic floor due to temporary like menopause-like changes. Lymph changes can also occur, and that can cause changes in the pelvic floor region, and also pelvic floor physical therapy can help with that. And then also, if we're talking about like a mastectomy, that can change what posture looks like. There can be pain in the upper chest cavity. That can change how much you're scrunching forward, which can change the pressure on the pelvic floor, which can lead to more leakage. So I hope that just paints a big picture of how there's, of course, yes, I'm a pelvic floor therapist. We're zooming in on the pelvic floor to help treat that area, but it's not just that, it's the whole person. What's going on up in the chest can definitely impact what's going on near the bladder. And then again, it would be incorrect of me not to just acknowledge the other male anatomy cancers that can occur: colorectal, prostate, urinary bladder, kidney, renal, and how that can cause similar symptoms to what females can feel. So here's an overflow flow chart just to show where physical therapy comes into this. So you get the cancer diagnosis. Obviously, there's a lot that goes on with that. There is treatment. So surgery, radiation, chemo, hormonal therapy, targeted therapy, immunotherapy. These can change the tissue, nerve function, hormones, scars, scar tissue, all of that. That can have an effect on the pelvic floor strength, pelvic floor coordination, the flexibility of the pelvic floor, tenderness of the pelvic floor, range of motion of the pelvic floor. And that can then cause symptoms. So that's when the patients start to really feel, hey, maybe I want to do something about this. Pelvic pain, maybe you're finding yourself go to the bathroom every 30 minutes. Maybe you're needing to wear pads to leave the house. Maybe you're realizing that you're not having regular bowel movements. You're going to the bathroom very quickly. Back pain can even be caused by pelvic floor dysfunction. And that's typically when we step in. You know, I wish that we were stepping in right before that arrow, but unfortunately, a lot of our healthcare system these days is like reactive. I wish it was a little bit more proactive, so I wish physical therapy was one arrow higher, but this is where we're at. So then physical therapy will then assess the pelvic floor, assess the abdomen, assess the person as a whole, and then treating any pelvic floor muscular neurological impairments to help to rehabilitate, improve function. So we're working on, let's say, strength first to improve the ability to stand up from the chair without leaking, and then that can lead you to be more comfortable going out to dinner. So increased participation in life is the goal. So next I'm going to go through the treatments themselves and how they can have potential side effects on the pelvic floor. I am not going to pretend to be an expert on the treatment. I am on the rehab side, but I think it is important just to note how these things can come about. So here are both the relevant short-term and long-term side effects. Now I know there are other side effects, but these are the ones that can impact the pelvic floor itself the most. Again, especially with surgery, there can be pain, which can cause guarding. It can cause the tissues to not be as flexible. There can be scar tissue. There can be changes in sensation that can cause weakness in the area. It can change body mechanics. So surgery is a big one that I find I'm getting referrals for to help to improve some sort of dysfunction that's going on. Radiation, so a little bit more localized, obviously. Radiation is shown to unfortunately cause fibrosis and stenosis of the tissues around the pelvis. So that can cause like a narrowing of the vaginal canal or the rectal canal, changes the flexibility of those tissues significantly, which can also cause pain and also apprehension of any sort of activity in that area. And with that, there can also be a change in the contractile, like the ability for the muscles to contract. So the muscles may feel a lot weaker, even though they're also tighter. They may not have that ability to contract as well. And that can cause some GI dysfunction, urinary dysfunction as well. And then with chemo, again, weakness and fatigue is a big one. There can be other sorts of symptoms that are occurring, but I find that a lot of times the chemo can affect the pelvic floor because of weakness and fatigue and just how that's causing the whole body to start to have different muscular imbalances. And again, everything is connected, so there can be carryover effects at times. And then here are the more systemic treatments. I clumped them all together just because there isn't as much research on the side effects and pelvic floor treatment here, except for, very importantly, hormonal therapy, especially anti-estrogen therapy, causing genitourinary syndrome of menopause. And so again, that is a cluster of symptoms that can be a temporary or a permanent menopause at any age. due to changes in estrogen levels. And that has a very direct effect on the pelvic floor as well, which I will go to here. So the genital urinary syndrome of menopause is a chronic progressive condition due to estrogen deficiency affecting genital, urinary, and pelvic floor function. So this will happen with the removal of the ovaries. So if the ovaries are removed with a surgery or a hysterectomy or for another reason, they can cause a decrease in estrogen levels. Also, hormonal therapy, again, if there's a specific plan to have the estrogen levels decreased, that can bring on these symptoms. And then, yeah, so the genital symptoms that can come about from estrogen changes and decrease in estrogen include vaginal dryness, burning, irritation, itching, decreased lubrications, like a dryness again, feeling pain with intercourse specifically, and then a thinning or loss of elasticity in the vaginal tissues. Commonly, you'll see that being called vaginal atrophy. I don't really love that term because I don't think it's describing everything that's going on, but there's like a thinning and just like a loss of the plumpness of those vaginal tissues. Also worth noting that these are symptoms that can come on with just normal menopause from age as well. So again, a lot of times I'll have patients come in talking about when their symptoms started. Maybe they weren't even referred because of cancer at the time, but then kind of piecing it together of, oh yeah, I guess my leakage did start to occur like shortly after my hysterectomy 10 years ago. But I always thought it was just age. Well, maybe there's more going on there. So again, this can cause increased frequency and urgency of urination, feeling like you have to go to the bathroom super quickly, like that key and door syndrome where you're commuting home, and then the closer you get to your apartment, that urge is getting faster and faster, or stronger and stronger and stronger until you suddenly can't get to the bathroom on time. It can cause painful urination. Recurrent UTIs is another symptom. Again, that usually has to do with the decrease in that plumpness of the tissue, causing it more likely for bacteria to be kind of uptaken into the urethra. So that's another symptom that oftentimes gets overlooked, but I think is being treated better these days. Stress incontinence, so leaking when you're coughing, sneezing, waking up at night to go to the bathroom. And again, this also has pelvic floor implications of decreased support of the organs, more discomfort in the area, and then sexual changes as well. So enough about all of that. Let's get to what pelvic PT actually looks like. So pelvic floor physical therapy evaluation and assessment. So you come in for your first day, you'll be sitting down. There's a lot of talking that should be occurring that first day. So asking questions, discussion of what you're actually here for, right? Like hopefully it's not just because your doctor said so. Hopefully there's something that you are looking to improve. So discussing what you want to improve, what's going on. There's definitely going to be a discussion of the cancer diagnosis, treatment. So we'll be asking questions on dates of surgery, what types of treatment you've had, is there going to be potential for more treatment in the future, etc. Staging of the cancer, all of that other information that we want to know. Even if you're coming in for just a urinary complaint, so let's say you're just coming in for leakage, nothing happens in isolation, and these muscles are connected to bowel and sexual function as well. And again, also your back, your breathing. So we're also going to review bowel and sexual and pelvic pain symptoms. Even if the only thing that you're really worried about right now is the leakage, there may be other things that can clue us into how to best help you and how to best treat you. And then, of course, addressing any sort of changes in energy, scar tissue, mobility, and quality of life concerns. We're always considering the emotional impacts and the medical trauma of a cancer diagnosis and cancer treatment. And then most importantly, in my opinion, or maybe not most importantly, but super, super important, is what is the patient's goal? What do you want to get back to doing? Is that leakage preventing you from going to yoga? Is that leakage preventing you from going out to eat? Is it a financial burden because of the pads that you're having to buy all the time? Like, what is your goal and how can we get you to a point of, hey, physical therapy was a success? After we do all that good talking to figure out what's going on, typically there's a movement and postural assessment. So again, we're zooming out first. We're not zooming into the pelvic floor. We're looking at how you're moving overall as a human. So with that, we're looking at your breathing mechanics, strength in your core, your legs, your hips, balance, your abdomen, scar mobility, all of that. Here's just a good picture, again, showing how the diaphragm, the abdominal wall, and the pelvic floor are all connected with the back as well. And then here are the layers of the abdominal wall that we can assess. So then the pelvic floor muscle assessment itself, crucial to highlight that, especially if patients don't know what they're coming in for the first day, we want to really describe what this looks like before any consent is even given, but we are always asking for consent. So this can be an internal or external exam if the internal exam is not consented to, and if the external exam is not consented to either, that's totally fine. We can address as providers. So with this, we're looking at the muscle strength, tone, coordination of the pelvic floor muscles themselves. We're looking at pain, we're looking at the flexibility, we're looking at scar tissue in the area, we're looking at how well those organs are supported. We're adapting for post-surgical or radiation changes, providing really gentle touch as needed, trauma-informed as needed. And again, this can be deferred if you're not ready. So here's just a good picture of what that can look like. So this is someone lying down face up on a table. Also important to note that this is not a gynecology exam, right? We are using our finger with a glove and lubricant to gently assess for the muscles. There's no speculum, there's no stirrups. Typically it is a comfortable bed with pillows and sheets, and we're really having like constant communication throughout to make sure that you're doing okay and that you're understanding why we're doing things. But again, we're looking at tissue strength, tissue endurance, the ability to contract the muscles, the ability to repeat that contraction. We're looking at how well can you push, how well can you pull the muscle up? Do you have any tenderness? Is there scar tissue? We're looking at all of those things, both visually first, but then also with our finger. Here's another good few pictures just showing what that can look like. So I like this first picture on the left because it shows the muscles. So we are palpating, we are touching to see how those muscles feel. We are palpating and touching here to see how well you can squeeze and lift our finger. So then after all of that, we come up with a plan of care for you. So explaining the symptoms, talking about what your treatment goals are again, and how we can get there through the treatment, providing home exercises that first day as appropriate and as possible to get you started. And then also just discussing how frequently you should be coming in. I find a lot of patients end up coming in about once a week, but if your pelvic PT is hard to access sometimes, so maybe you're driving 2 hours, your therapist can adjust to that. So coming in once every 3 weeks if needed, coming in more often if more hands-on work is needed. It can really be discussed with the patient. And then of course, throughout all of this, we're also communicating with the doctors, the referring providers, and then any precautions or contraindications for your specific cancer or cancer treatment are considered throughout as well. Okay, so treatment techniques. I'm just going to go back to this for a second to say that this is not any specific advice for any one of you. My most important takeaway with this is that if you're having a thought in your head that you should try pelvic floor physical therapy, I encourage you to go get an evaluation so that you can have a personalized approach and treatment. I don't want you necessarily to say, oh, well, I think I have tightness, so I'm going to try doing this. I can't stop you if you do, but I would definitely recommend going to see someone to have that formal evaluation to really tailor it to your needs. So one thing that we provide is pelvic floor manual therapy. So this is basically, but much different as well, a gentle hands-on release of the tight muscles. So it's not massage, we're not like moving through the muscles, we are holding and we are gently releasing to improve tissue stretch tolerance and tissue flexibility and to decrease pain. We can do this internally by inserting our finger to either like our first or second knuckle and then gently pressing on the muscles internally if that's where the complaint is happening. And it can also be done externally, whether that's because it's more appropriate for what the patient needs or if that's because that's what the patient is comfortable with. And then with externally, that can be done over the skin or even over clothing. So again, this is hands-on direct touch to the pelvis and the pelvis muscles to decrease pain, to improve sensitivity, and to improve flexibility. This is often used to support healing after surgery. So again, that tightness that can come from the guarding from surgery or scar tissue, with pelvic pain complaints, with pain with intimacy and penetration, with symptoms of going to the bathroom more frequently. A lot of times that can be caused by tightness. Feeling like you suddenly have to go to the bathroom, that can be caused by tightness at times. So that's typically when we're doing this. So this is a picture of when the therapist is providing it for the patient. You can also perform it on your own at home, and this is great for the patients that are ready to continue on their own or patients that need more work and they can't come to the clinic that often. And this is what we call a pelvic wand, and it can be inserted vaginally or rectally. And we would instruct you specifically on how to insert it and release those muscles on your own. So this picture on the right side is showing how that wand can be inserted and it can press on the muscles that are having tightness, okay? And again, this is instructed in the clinic so that the patients feel comfortable with doing it on their own before we just send you home to do it. Similarly, vaginal dilator therapy. So the last picture, there was like a wand-like shape. These are just typically straight dilators in progressive sizes. We're usually using the wand for patients that have muscle tightness in a specific muscle or maybe pain in a specific muscle that needs to be released due to any sort of muscular compensations, whereas the dilators are used typically when there's any sort of vaginal stenosis or narrowing due to radiation. So there are progressive sizes. The smallest size is probably smaller than my pinky, and the largest size is definitely larger than like any speculum. Maybe would be appropriate if a patient's trying to be able to tolerate a transvaginal ultrasound. So the patients progress through these sizes with the guidance of the physical therapist, only progressing when the one size is pain-free and tolerated really well. So if there's any pain or any apprehension or any guarding or like clenching with even the attempt to insert one of these, then you're not ready to go on to the next size. So we want to really make sure that patients are super comfortable with one size before progressing to the next size. And that's how those slow tissue changes can occur to allow for pain-free penetration again. And again, that could be for tolerating a gynecological exam, or it could be for intimacy with a partner. Here's the picture of a person inserting it on their own here, set up in a nice comfortable position. And this is actually a fairly good picture of just what it looks like to be in pelvic PT as well. If we're doing any hands-on treatment on the table, is you're going to be in a very comfortable position like this, but then also covered by a sheet to make sure that you are draped and covered appropriately so that you feel comfortable throughout. And we're only exposing what needs to be exposed at any moment. And then here are just some other examples of dilators on the side. Next is abdominal massage and scar mobilization. So any sort of surgery in the abdominal area, we can provide specific scar tissue massage. We can also teach patients how to do that. We can do more general massage around the abdomen. If there is tightness near the diaphragm, we can do a diaphragmatic release. If there is tightness over the bladder, we can do a slight light pressure release there. There are different hands-on techniques that we can provide to the abdomen. And again, the abdomen and the pelvic floor work together so much that if you have any abdominal pain clenching, your pelvic floor is also very, very likely also clenching and has some stiffness to it. So the abdominal massage and scar mobilization is very important as well. This is actually a picture of a C-section scar and scar massage, but all the techniques work the same. We're working on just getting more tissue there, the tissue moving better there. And I will say this too, is that it often gets overlooked as something that can be contributing to other symptoms, is scar tissue that was not addressed properly immediately after surgery. Now, that doesn't mean that going into physical therapy for this 5 to 10 years after surgery, you're a lost cause. But the earlier that you get this moving and you get this stretching the way it should, once you're cleared to from the healing, the better. Which also brings me to diaphragmatic breathing. if there is one intervention that I could give every patient, it would be diaphragmatic breathing. It is so important to be able to breathe properly through your abdomen for your pelvic floor health. Again, that diaphragm is the ceiling, the pelvic floor is the floor, the abdomen is one wall. When we take a deep inhale, our diaphragm should be expanding, our abdomen should be expanding, and with that, that allows our pelvic floor to also lengthen. So if we're having any tightness or pain symptoms, or again, urinary frequency, urgency, working on the inhale part of that deep breath can be very helpful. If there's any strength or coordination issues and you're having difficulty contracting and even finding your pelvic floor to perform a contraction, the exhale can be helpful because on the exhale, our belly button should be gently coming in towards our spine. Our rib cage is gently, our diaphragm and rib cage are gently moving up, and then our pelvic floor can also gently squeeze. So this is what I just explained here. So again, as we inhale, diaphragm can go down, abdomen goes out, pelvic floor can relax down. And as we exhale, everything kind of comes back up and in together. So breathing is super, super helpful for pelvic floor issues. Here are some stretches. So these would be typically used for patients, again, that are having pain, tightness, or urinary frequency urgency symptoms. These are just generally some really good ones. A lot of them are yoga pose like happy baby, cobra, butterfly, deep squat. These all, any like hip opener is probably also going to help relax the pelvic floor, and any like abdominal opener is also going to help relax the abdomen. But again, these are things that you should make sure are appropriate for you before you go ahead and start doing them. And then lastly, I think probably a lot of people expect talk about pelvic floor PT to be all about Kegels, because that's the thing people know about, Kegel, 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 right? So that is actually not anywhere near as much of our treatment as people think, even though it's an important aspect of it. But pelvic floor strengthening, this is shown to be very helpful to build support of the pelvic floor and the abdomen, to help with bladder and bowel control, to decrease leakage, to help with stability through the pelvis, and to help with overall function. So we would see this with post-surgical recovery. If people are having leakage, sometimes this is appropriate. If people are having leakage of stool, sometimes this is appropriate. If there's urgency or frequency for going to the bathroom that is linked to weakness on our first exam, we would be doing these pelvic floor contractions. If there's muscular imbalances due to low back or hip pain, we would also be doing these muscular contractions. But again, this is where you want a specialized exam or a personalized approach, because sometimes patients think that, oh, they're having leakage, they need to be doing Kegels. But in reality, their pelvic floor is actually really strong, and potentially the Kegels are making things worse. And I don't say that to scare you into like trying things on your own, but it's not so black and white as, you know, leakage equals weakness, I should do Kegels. There's a lot of other things going on. So here's just another picture of what that Kegel looks like specifically. There's a lot of training that we do to help patients figure out how to do it correctly if they cannot do it correctly on their own. And I don't have the numbers up here, but I think it's something like at least 50% of patients, when they try to do a Kegel, they're not doing it correctly. So even making sure that patients know what they're doing first is really helpful. And sometimes as soon as they know what to do, then they can go and do it better. But it's hard to actually improve your strength if you think you're Kegeling and actually you're just squeezing your butt muscles. So we want to make sure that you're doing it correctly. Yeah. And then general strengthening, again, zooming out a little bit, we're strengthening anything else that is weak, anything else that has an imbalance to it. We're working on the whole person. We're working on posture to help align the spine more, to align the diaphragm more so that you can breathe better. We're working on leg strength so that your pelvic floor doesn't have to take so much of the load when you are going up the stairs, to decrease leakage, all of that. All right. So I don't think I have time for a case study, and that's okay, because we'll have time for questions later. But yeah, this was great, and I'm very happy to have shared this information. I hope you guys got something out of it.
Thank you so much, Lily. And now we actually have a patient who's experienced PT. It was quite some time ago, but she's going to tell us a bit about her experience. Her name is Yvonne Soden, and Thank you, Yvonne, for joining us.
Thank you. Okay, so I'm Yvonne Soden. I live in Brooklyn, New York. And I had in 2022, I was diagnosed with endometrial cancer. And I had a total laparoscopic hysterectomy in February. And then it was followed by 3 rounds of brachytherapy radiation. So after the radiation, I started having urinary frequency and sort of not really incontinent, but I was going often, and so I was having problems with that. And originally, so I spoke with the nurse practitioner, and so first they referred me to somebody. I go to Memorial Sloan Kettering, who I spoke with, and she gave me a whole booklet, and it was all about Kegel exercises. So I did, I do appreciate and feel like a lot of what Dr. Lilly told us is so important, because it isn't all about Kegel exercises at all. In my situation, and then, okay, so I listened, I took all the information, and then I discussed it with the nurse practitioner, who suggested maybe I should go further to pelvic floor therapy. So it was very difficult to find floor therapy. Most places that I went were like booked for like a year, and I could, and it was very frustrating to find a place. Finally, I did find a very nice facility, Beyond Basics, in Manhattan, and I found them to be very professional and very informative. And I went through, so when you go through something that Dr. Lilly has discussed, you really see this is what it's about. It's not just about, it's about the pelvic floor, and it's about all the other muscles that are supporting the pelvic floor. And I was so impressed by the physical therapy there, because I did have the exam, and I was told not to do Kegel exercises. So this was the first surprise, because I have been doing them all my life practically, even before even before I had a hysterectomy. I don't know, it was ingrained in me to do Kegel exercises. And so I had been doing them. And so here I was, and she said, I'm very tight, and so it was a surprise. And that's why it is important to get an evaluation if you have any kind of symptoms. I found what Dr. Lilly has discussed has been so informative and helpful and useful, because not only do they work on the pelvic floor, when you go to regular physical therapy, like you go for a knee or a hip, that's all, they just concentrate on one area. That's all they're allowed to do, actually. That's what I've been told. Like if I go if I have 2 ankles, I have to work on 1 ankle first. So this was amazing because it's comprehensive. It's, she worked on my hips. She worked on, because I have problems. I have scoliosis, and so my posture is not good, and so that affects the urinary functioning, and it just entails so much. And I just found, as Lily her discussion is so comprehensive and so complete. This is what I found when I went there, and it was a big, revelation to me. And, and it's tailored, so personal to each person, which is so amazing, and and it helped me a great deal. So I went for about a year, and I have exercises to do on my own, and I've been doing, I still have some, frequency, and so, the thing is, it's hard to travel to Manhattan so often. When I used to, originally I had gone, and I was very pleased. And the woman who I used she had retired. She left. She went to moved to Florida. So at that time, I decided to stop. I'm not sure if I may return, though. Not, I'm thinking of going back, because it really is the greatest kind of therapy to get, and I just, let's see what else. Oh, and yeah, so I use the Reverie Plus, for a lubricant. I just wanted to mention that with the dilator. And because I do have a specific area, I know I've been examined, I have scar tissue, and I know where to use, where to emphasize it, but I use it throughout the whole vaginal area. I also have very narrow, so it helps. I've never increased from the small size, but that's just where I am. So I stay there because that's where I'm comfortable, and and so the doctor will just do that, that's fine. And I use a lubricant. Lubricant I use is, let's see, Yuba Lube it's called. So I use what do you call this? The Bonafide Plus. That's the moisturizer, like in the evening, and then the next day when I use the dilator, I use the Yuba Lube. I do it maybe twice a week, like something like that. But I can't, and it's just done so comfortably, the pelvic floor, you do feel comfortable, you do feel privacy. It is an amazing type of therapy, because I also didn't know what to expect. And I had my own room, and it's just very personal, and it's a wonderful type of therapy. And one more thing I wanted to say is that my husband had prostate cancer. After I had my hysterectomy, he ended up with prostate cancer. Thank God we got MSK, and thank God we're both okay. So far so good. And I suggested to him, actually, because he was having bladder issues, the pelvic floor, because many doctors do not mention it. And so then he asked the doctor, he said, "Oh, that's a good idea." And he did, and he's doing really, really well. So I thank you, Dr. Lilly, and all the therapists out there who do this work, because it really involves a lot of knowledge. It's not just one little Kegel. It involves so much, and it's really a wonderful type of therapy. So thank you.
Thank you, Yvonne. We really appreciate your sharing your experiences. And if anyone wants to ask Yvonne a question, please put it in the Q&A. We're going to start the Q&A now. You can still submit questions in the Q&A section at the bottom of your screen. We had a lot of pre-submitted questions and live questions. Lily, you did such an amazing job that I think like 80% of the pre-submitted questions were already answered. So I'm going to focus a little more. Actually, one thing, how long does it take to see results with this kind of therapy?
Yeah, it's really hard to answer. So like broadly speaking, I will say a lot of my patients I'll see typically in the range of, well, let me back up. I think it matters a lot if there's tightness or if there's weakness. I find that when there are changes that are more related to tightness, it's a longer plan of care. And those patients I have seen, just from my experience throughout the years, anywhere from, as short as like 6 weeks of feeling really great, to like a year, to be completely honest. And I will also say that a lot of times we're not leaving patients with, okay, good to go, like done forever, never have to think about your pelvic floor again. There's usually a period of making sure that the patients feel comfortable discharging from physical therapy and have tools for things to do on their own. And sometimes that even looks like maybe seeing a patient once a week for the first 8 weeks, and then going down to every other week. And then, okay, they're still seeing progress on their own. So maybe a check-in like once a month. And then maybe, okay, you're still doing great, I'll see you in 3 months. So it really can depend. But I do find that with patients that do just need pelvic floor strengthening, so the patients that are more appropriate for just like, well, I wouldn't say just Kegels, but like Kegels and like strengthening through the abdomen and hips, and have less complicated factors going on, those patients tend to see progress much more quickly. And the typically strength changes take place in the course of like 4 to 8 weeks. So that's the same as when you go to a gym, you start to feel stronger after 4 to 8 weeks. The same is for your pelvic floor.
Okay, great. I think a lot of people have mentioned that the gynecologic oncologist doesn't always tell them about pelvic floor PT. And so I think they're wondering, you know, a little bit more about, should they talk to the doctor proactively? Are there ways to find out about pelvic floor physical therapists online? Like, what is kind of the best thing?
That's a great question too. I said this before the presentation started, just in the conversation, but I think pelvic PTs also we have work to do in educating the doctors to help more on the like front side of this so that patients don't have to advocate so much for themselves. But I will say that typically if you do bring it up with your doctor, hey, you could even make something up. I have a friend that did pelvic PT and it was really helpful for them. I'm wondering if you think that would be appropriate. That's one way to go. But also depending on which state you live in, there is a law called direct access. And at least in the state of New York, I believe it's the first either 30 days or 60 days of physical therapy treatment. You can do that without a doctor's referral. So you could call up Beyond Basics and say, hey, I want to try physical therapy. And again, depending on you know, some other various factors of your specific case, it would be appropriate to do an evaluation. And then afterwards, if the PT decides, hey, yeah, you are appropriate for physical therapy, then you could just get a script from your primary care physician even. It doesn't have to be from a oncologist. It doesn't have to be from the surgeon or anything like that. The only piece of that is a lot of times as the physical therapist, we'll still want to communicate with those doctors to make sure that there's that we know everything that we need to know to best help you. But the script does not necessarily have to come from that doctor. And there are state-by-state laws that allow patients to see the physical therapist first before going through all the loops of having to show up with a referral.
Okay, thank you.
Mm-hmm.
There a lot of people wrote about urinary frequency, urinary leakage, incontinence. And is there, I know that each case is so individual. Is there any one particular part of the pelvic PT plan that is specifically very helpful for urinary related issues?
Yeah, so that's it's hard to answer. So for urinary incontinence, a lot of times improving the patient's coordination with their pelvic floor muscles can help. So either whether they need to strengthen or relax more, just improving the ability to let those patients have a better idea of what their pelvic floor is doing can be helpful. And this is something I didn't even get into during the presentation, but there's also something called bladder retraining, which includes teaching patients how to suppress the urge when they get the urge to go. So if you're sitting on the subway and you still have 2 stops before you get home and you're finding, oh my gosh, I have to pee. One of the first things I'll do is with patients that have frequency, urgency, or incontinence is teach them how to apply those techniques so that they can calm down that signal of having to pee. And that's a really crucial part. That's called urge suppression. If anyone wants to look that up on their own, there probably is good information if you just Google that, urge suppression. That can be very helpful very quickly, as long as you have the coordination of your pelvic floor. Yeah.
Okay, thank you. And what do you consider frequent for going to the restroom at night?
I always kind of, so what is said is that normal frequency is 3 to 4 hours, or about like 6 to 8 times during the day, and 0 to 1 times at night.
Oh, wow.
I will say that that can also vary a little bit depending on how much fluid you drink, depending on your age, if you are postmenopausal. But yeah, patients are oftentimes shocked by hearing those numbers. So like 5 to 8 times during the day. Yeah.
Wow, wow.
Mhm.
Before I leave the bladder, somebody asked about Uresta bladder control device. Do you know anything about that?
There's so many devices. I don't that one off the top of my head, I don't think so.
Okay.
I apologize. Yeah.
No problem. And I know you talked about the dilators and the different those techniques for the menopausal syndrome, the vaginal atrophy. Are there other and Yvonne, thank you, brought up some other things that she has used. Where's a good place for people to find out more about tools, medication, anything that they can use, or will the physical therapist really go through all of that with them?
Yeah, the PTs will go through all of that mostly with the exception of any sort of like topical ointments or like creams that we can't prescribe. And then typically the gynecologist would be the one addressing those things. Again, keeping in mind the cancer history and like risks of like topical estrogen and anything like that. So that piece has to come from the doctor, but everything else physical therapy is covering.
Oh, okay, great. Some people asked about very specific conditions. One was, and I'm not sure if I have this right, if it's called a uterus prolapse or a vaginal prolapse.
Yeah, so that is when it sounds scary, but it's not quite as severe as what it sounds like. It's when the organs, either the uterus, the vagina, the bladder, or the rectum, basically drop down in that cavity a little bit. So if you imagine the pelvic cavity and the pelvic floor is that hammock, it's when one of those organs just kind of like sinks down a little bit more. And so typically what it can feel like is something's bulging out of your vagina. And there's different grades to it. If it's one of the smaller grades, it can be improved significantly with strengthening exercises. If it's grade 4 and it's actually like significantly protruding outside of the vagina all the time, typically that's a surgical consultation. And that is something that can happen just from like muscular imbalances. It can happen because of childbirth. It can happen because of age. It can happen for multiple reasons outside of any sort of cancer diagnosis as well. But strengthening is the physical therapy intervention to help with that.
Thank you. Somebody also asked if pelvic floor PT can help after hip surgery.
Yes, definitely. Yes, like I said, 2 of those muscles that insert into the pelvis are hip muscles. And a lot of times any residual issues that are not improved with the surgery or with hip physical therapy can be addressed through pelvic floor physical therapy.
Okay, great. Somebody else asked if can a pelvic floor PT do manual lymph drainage in the pelvic area?
So there's a different certification and different training for lymphatic massage techniques. I personally don't have that training. A lot of pelvic health and women's health therapists do. Over time, like more recently, they've kind of separated a little bit where most of like 10 years ago, a lot of people were having the training together. So short answer, there are 2 different things, but the likelihood of a pelvic floor therapist also being able to do that is somewhat high.
Oh, okay.
Yeah. Otherwise, I will say you can search for a certified lymphedema therapist, CLT. That is the type of therapist that would be able to do that for you.
Oh, great. Thank you. And also, generally speaking, I know we touched on insurance a little, but because a couple of people wrote about some issues they had with getting insurance. And somebody was told to get gabapentin shots. Have you heard of that at all?
Gabapentin is a medication that helps with nerve pain, and that would be done by a physiatrist or a doctor, not a physical therapist. And in terms of the insurance, we bill insurance just like any other PT would, like for the low back. Some insurances are more likely to deny us because they don't see going to the bathroom or having sex as important things, even though they very much are. So we're more likely to be denied, but we're still submitting everything the same. So yeah.
Okay. And I think I have time for one last question. Will you know, as the patient, that your pelvic floor is getting stronger? Can you feel it, or?
A lot of times, yes. A lot of times, yeah. Most often, patients will be able to say, "I feel myself like squeezing better," and they can feel that connection more. Yeah.
Well, that's great to hear. Well, thank you to everyone who submitted questions. I know we had a limited time, but we really appreciate that. And thank you so much, Lily. This was incredibly interesting and thorough, and I feel like we all learned a ton today. So we really appreciate your participation. And Yvonne, thank you for giving us that personal perspective. I think that's really, really helpful to hear how much it helped you. And Thank you to everyone who joined us today. And we'll have a recording of the program available on our website in a couple of weeks. And please check Share's website for upcoming educational programs and support groups. And don't forget to follow us on social media as well. And we do have a survey at the end of, it will pop up at the end of the webinar. And please do answer those questions, as it helps us with future programs, and all surveys are anonymous. And thank you again to everybody, and have a wonderful rest of the day and weekend.
Thank you.
Thank you.